Good evening, everybody. We have literally just opened the door to let people in to the event. So I'm just gonna give people a minute for any final joiners before we kick off. So thank you for joining us. Please bear with us. We will get started in the next minute. So we're at 6:31. I want us to get started because I don't want to lose valuable time from the point of view of presenting. So first things first, a warm welcome, a very warm welcome from me to our second Spotlight event brought to you by the Frank Williams Academy, which is of course part of the Spinal Injuries Association. A special welcome to those returning after our recent Skin Spotlight event. For those of you who weren't at the last one, my name's Karen Pratt. I'm head of the Frank Williams Academy at SIA, and I'll be your host for this evening's event. Tonight's event focuses on bladder health and care. And over the next 2 hours, you'll hear from a panel of expert speakers who will guide you through essential information about bladder function, common challenges, and what good bladder management looks like following a spinal cord injury. Before we begin, thank you to everyone who has submitted questions in advance. We've had many, and where possible, we've grouped similar questions together. There is still the opportunity to submit further questions. You can do so by using the Q&A feature button at the top of your screen. Please use the Q&A button rather than the chat button, and you should be able to find this across the top banner of the screen. We will, of course, endeavour to answer as many questions as possible, but the volume may outweigh the time that we have this evening, but we'll see what we can do. This is a live event and we are recording tonight's session so that members can watch it later when it's available on our website. Your cameras and microphones are switched off, so sit back, relax and enjoy the event. And our behind the scenes team is supporting the session and will handle any technical hiccups should they arise. So why are we here? Well, spinal injuries disrupts the communication between the brain and bladder, often resulting in a neurogenic bladder and impaired bladder control. As a result, people with spinal cord injury are at increased risk of kidney complications, highly susceptible to urinary tract infections, vulnerable to autonomic dysreflexia, often caused or triggered by bladder issues, and are advised to have regular monitoring. Many people say that bladder issues are more disruptive than mobility challenges, yet they are often embarrassed to discuss or talk about them. Tonight is about normalising the conversation, learning together and strengthening confidence in managing bladder health. Our aim at SIA is that everyone affected by spinal cord injury has the opportunity to live a fulfilled life. Understanding and managing bladder health is a vital part of that. I've already said that I'm joined by a panel of expert speakers, and they this evening include Sheila Reid, who's a consultant urologist surgeon and one of SIA's trustees, and she'll be kicking us off with talking about the anatomy and function of the bladder. We're also joined by Katie Eyre, who is also a consultant urological surgeon from Buckinghamshire Healthcare NHS Trust, and she's going to be discussing bladder and catheter management approaches. We've got Ian Beckley, who's a consultant urologist from Mid Yorkshire Teaching NHS Trust, and he's going to be talking about the surgical management options. We've got Miłosz Nadim, who's also a consultant urological surgeon from South Tees Hospital NHS Foundation Trust. And she's going to be speaking about UTIs, including the causes and prevention. And then we're joined by two of SIA's specialist nurses. We've got Mel Williams and Carol Adcock, who will be talking about the clinical support that's available to you here at SIA. And then finally, we're joined by Ian Anderson, who's one of our trustees, who's going to talk about lived experience and some of the bladder challenges that he's faced during his time. At the end of the evening, all speakers will join the panel for a Q&A discussion using questions that have been submitted in advance and during the event. I'd like to thank all of our guest speakers for their excellent contributions and for being part of this event. We hope you leave tonight with clear, practical insight into bladder care. Following the event, you will receive a document containing helpful links from the presentations and a glossary of key terms. But without any further ado, I'll now hand over to our first speaker, Sheila.
Thank you very much, Karen. I am just going to share my screen. Karen, can you just confirm that that's sharing okay, please?
Yep, perfect.
Super. Well, thank you very much for that introduction. As Karen said, I'm Sheila Reid. I'm a consultant neurourologist and I'm attached to the Sheffield Spinal Injuries Unit. I actually took semi-retirement about 18 months ago and I've had a bit of extra time and I've been very lucky that I was made an associate trustee for the SIA and I've thoroughly enjoyed working with them. So my remit is to talk to you about pathophysiology. Now that sounds like a very complicated thing, but I will try and make it as least complex as possible. So the first thing as urologists we have to think about are what are the bladder problems that patients have with spinal cord injury. And the first and most important problem is the potential for increased bladder pressure, which can cause the bladder to be unsafe. The second problem is what we call an overactive bladder, a bladder that contracts too much. This may mean that you need to wee very often, you may not be able to control your wee, and you might wet yourself. Third problem is that the bladder doesn't contract efficiently enough and therefore doesn't empty. Now, the problems 2 and 3 can occur at the same time. You can have a bladder that contracts too much, but that doesn't empty. Fourth problem is a weak sphincter. So the sphincter muscle is the muscle that keeps you dry and stops you wetting yourself. And if neurologically that's not working properly, you will find that you leak when you move around. That's called stress incontinence. Maywash is giving us a lecture on urinary tract infections, and throughout it we'll also be discussing complications. But I wanted to just talk first about the urological services that you should be being offered. And I want to introduce you to this document. It's what's called a GIRFT document, Getting It Right First Time. And there are GIRFT documents for many different types of problems. This is regarding functional urological problems, so that people who have bladder problems because they don't function properly, and that includes spinal cord injury. And in that document, it points out that spinal cord injury is a complex neurourological problem and that there should be specialist urologists involved in your care. And specialist urologists are attached to most of the spinal centres, and you're meeting 4 of us today, but there are many more of us, although unfortunately not all the spinal centres have got specialist urologists. So as a urologist, my role is to assess and manage bladder safety, to investigate and manage pathology, so things that may be wrong, to assess and manage incontinence, including poor bladder emptying, and manage recurrent urinary tract infection. But to do that, I need to understand the spinal cord injury and how that affects the bladder. So I'm going to try and summarize this to try and explain that to you. The first thing to remember is that there is a difference between the levels of where the spinal cord itself is and your vertebra. So the vertebra are the bones down the middle of your back, which protect the spinal cord. And the spinal cord actually ends at vertebral level, first lumbar vertebra. And that is, in fact, if you put your hand to the bottom of your rib cage and you feel the vertebra around the back there, that is roughly that area. Anywhere below that is called the cauda equina. And the cauda equina is made up of the nerve roots. And I'm sure you can envisage, an injury that affects the nerve roots is going to behave differently to an injury that affects the actual cord. The actual nerves that supply the bladder come from the sacral level S3. So that's the sacral spinal segment, not the bony level, S3. And that's actually sitting up at the bony level of L1 or just above that. And that sacral 3 level has got two very important nerves. The first one is the nerve that supplies the bladder and causes bladder contraction. And there's actually a reflex down there. When the bladder fills, that nerve will be triggered and the bladder will contract. And you don't need your spinal cord attached to your brain for that to work. That will still work. That will work as a reflex. The second nerve is the one that supplies the sphincter. This also comes from the third sacral segment, and it causes contraction of the sphincter. And there's another reflex down there. When the urine starts to come into the sphincter, it causes contraction. So if you can just imagine, if your spinal cord is not connected to your brain, therefore nothing is controlling these reflexes, but your spinal 3 segment is working fine, when your bladder starts to fill, it will automatically contract. Some of you may manage your bladder with reflex voiding, but you may actually also be contracting your sphincter, and this can cause high pressures and potential problems. So the very last point of this long slide is that there is another important nerve innervating bladder, and that's a little bit higher than the sacral segment. It's called the sympathetic nerves. And it means when your bladder fills, your bladder relaxes. This is something that happens automatically if your spinal cord is attached to your brain and if your sympathetic nerves are working properly, but may not happen in spinal cord injury. And for that reason, we talk about bladder safety. An unsafe bladder is one that puts the kidneys at risk. And the kidneys are put at risk if the bladder pressure is too high so that the kidneys cannot allow the urine to drain into it. And if you can imagine, it acts like almost like a blockage. If the pressure is too high, the kidneys will then swell up, and after a while, they will actually stop working. And that's really important. And it's also the reason why we do ultrasound scans to look for this, because we can see the swelling on your kidney. And Katie's going to talk to you a lot about that in her next lecture. So this is the second document I want to bring your attention to. This is what we call a NICE guideline. NICE is the National Institute of Healthcare and Clinical Excellence. And what these documents show, they're guidelines for how we should manage these things. There are links for this on the website. You'll be sent links for this later. And this looked at and advises how we should manage bladders in specific neurological problems. And it includes spinal cord injury, and spinal cord injury falls into two of these sections. It falls into the suprasacral section, and that's the section where the sacral part of the spinal cord that I've just spoken to you about works, but the injury is above that, therefore the brain is not connected to that. And the second one is the sacral one, where that sacral part of the spinal cord is not functioning for whatever reason, and therefore there is no nerve supply to the bladder or sphincter. And there are recommendations of how this should be monitored, which again, Katie will talk about in her next lecture. So the last document I'm going to bring you to is probably the one you'll find most valuable. It's the Spinal Injuries Association fact sheet. It's a bladder management fact sheet. You can find it on our website. You'll get links to it as well after this talk. I think it's a really good fact sheet, and I hope you'll find it valuable. So to try and help us explain things, we decided that we'd do our presentations based on 3 fictitious patients, and these patients have got different types of spinal cord injury. We appreciate that you won't necessarily be the same as any of these patients, but we hope that by highlighting these, it will have some sort of explanation of the diversity of bladders that can occur in patients with spinal cord injuries. Our first patient is a 65-year-old man, And he has a C5 Asia A traumatic injury 20 years ago. And that means that his fifth cervical spinal cord segment is the segment that works best. So his injury is below that. He will be tetraplegic. As an Asia A, this is a complete injury. And if you think back to my explanations of a suprasacral injury, this gentleman's S3 spinal cord segment is still functioning completely normally because it hasn't been damaged. What's not functioning is that it's not connected to his brain. And that means that as his bladder fills, it will contract. As urine starts to come into the sphincter, it will also contract, and he may develop prolonged high pressures in his bladder. So he does need to have monitoring and a sensible management discussed with him and his urologist. And he's been managing very well with convene drainage for many, many years, but something has changed. In this case, he's getting recurrent urinary tract infection, so he's going to need further assessment. Our second patient is a 24-year-old lady. Our second patient is a 45-year-old lady. I beg your pardon, I was jumping a slide. This lady had a disc prolapse. And her vertebral disc, remember the vertebral discs sit between the vertebral bones, and they were between the bones of the lumbar 5 and the sacral, the first sacral. That's the most common area to get a disc prolapse. And that's quite low down in your back. And that means that any injury that occurs will occur to the nerve roots, and we call that a cauda equina injury. And this lady will have, it's very difficult to predict a bladder like this because you don't know which nerves are being damaged or how severe the damage is, because how much of the disc actually caused a problem. Often in patients with cauda equina, she's got reasonable mobility and good hand function. And hand function is something we always ask as urologists, because if you have good hand function, you should hopefully be able to do intermittent catheters, which gives you lots more options for potential treatments. She is, however, very wet and also has fecal incontinence. Our last lady is a 24-year-old lady, and she's described as having a flaccid T8 paraplegia. So if we break that down, T8 means thoracic level 8, so she's got paraplegia. Below the level of that injury is not connected to the brain. But what's different to this lady and John, our first gentleman, is that she has had a condition called transverse myelitis, which has caused severe inflammation down her spinal cord. Now, it doesn't always cause very severe inflammation, but in this fictitious lady, it has. And it's caused damage to all of the spinal cord from the thoracic 8 segment down. None of those segments are working. And that means that the S3 segment, which she's relying on for innervation of her bladder and sphincter, is also not working. And that means that she will have no nerve supply to cause a bladder contraction, no nerve supply to contract her sphincter. You may think that that would mean she wouldn't potentially get high pressures, but that's not quite true. You still have to have proper assessment, because some patients with these sort of bladders will also not have the other type of nerve supply, which allows your bladder to relax as it fills. So all these patients have got significant bladder problems for slightly different neurological reasons, and they will all need proper assessment and management, which I know my colleagues are going to talk about next. So thank you very much for listening to my presentation. You will have opportunities for questions at the end, but I'm now going to pass you over to my colleague, Katie Eyre, who's going to talk to you about assessment and monitoring. Thank you very much.
Brilliant. Thank you, Sheila. Let me just share my slides. Super. So my name's Katie Eyre, and I am another consultant urologist. I work at the Spinal Injuries Centre at Stoke Mandeville, and I'm going to expand a bit on what Sheila has already talked about and just have a look at how we might go about assessing some of these different types of bladders that you can have in spinal cord injury, and then a little bit at the end about management. Now, whenever we do any tests or investigations, it's so important that we have an aim behind those tests, and you should always feel confident that when you have any sort of test or investigation for your bladder, that you know what we're looking for as urologists and what information we're hoping to get. And I feel like we can break it down into these 4 areas. So Sheila mentioned about pressure on the kidneys. So one of the things that really we're hoping to discover from some of the tests that we use is there pressure on the kidney, and how can we stop that from happening to protect your kidneys? We then want to make sure that we're managing your symptoms and ensure that you have social continence. Now, I use that word social continence because continence looks different for everybody. And some people are very distressed by a very small amount of incontinence and want to have that managed, whereas others are happy to manage with much more significant incontinence. And that's an important conversation to have with your urologist. There is then the very big issue of preventing and managing urinary tract infection, which my colleague Mewash will talk to you about later. And all of this contributes to maintaining your quality of life. Oops, sorry. So in order to do this, then we have a wide range of tools in our toolbox as urologists, ranging from urodynamics to different ways of investigating and looking into your bladder or taking pictures of your kidneys. And I'm going to try and go through some of those with you this evening. We also have some guidelines, and these are freely available on the internet. And Sheila has already mentioned the NICE guidelines on neuropathic bladder. And there are also some very extensive guidelines from the European Association of Urology, which were published last year and go into a lot of detail about investigating the neuropathic bladder, if that's something that you would like to read about. So we have our 3 case studies. We have John, we have Jane, and we have Laura, and Sheila's really developed those patient examples for you, and I'm going to use those and refer to those as I speak. So first of all, urodynamics. What is urodynamics? You might hear it referred to as video urodynamics, as cystoflowmetry, as pressure flow studies, and these are essentially all the same thing. And it is a test that is offered to the majority of people who have a spinal cord injury. And it's really the only test that helps us as urologists to understand how your bladder works. And you probably noticed, as Sheila was talking, through those little patient studies, that she said, oh, well, it might be this or it might be this. This person has this injury, but they might also have this problem. And urodynamics is how we start to tease out what is going on with the bladder. So what might you expect if you come to a urodynamics study? You should expect to bring with you a bladder diary, and that's a diary telling us what you drink and how much and how often you wee or use a catheter. And we know that these are quite difficult to fill in and that they are quite hard work, but it's a really, really helpful tool for us as urologists. It's almost as helpful really as the urodynamic study, because it gives us a snapshot into what life is like for you and how your bladder is working on a day-to-day basis. When you come for the urodynamic study, you will have a little tube put into your bladder and another little tube put into your bottom. So it is quite an invasive test. I always say to my patients, I can't dress this up and make it any better than it is, but I always try and talk to people, try and make people feel as relaxed as possible. It might be performed with you sitting down, sometimes lying, sometimes standing, and some units have a special table that starts off with you lying and then tilts to stand you up. Your urologist is likely to ask you to do lots of coughing, and the procedure may involve using X-ray to take pictures of your kidneys and your bladder during the procedure, but this isn't always the case. There is a risk of autonomic dysreflexia, so you may have some blood pressure monitoring if you have a higher spinal cord injury that puts you at risk of this. So I think all the people in our case study should be having a urodynamic study at some point in their spinal cord injury journey. And the test results will tell us how the bladder works. Is it too floppy? Is it too squeezy? Or is it just right? It tells us a bit about how the sphincter works. Is this too floppy? Is it too tight? Or is it okay? And how much pressure is there in the kidney? And as we know, pressure is bad for your kidneys, and this is one of the main reasons for doing this test. It's the only test really that tells us how best to manage your bladder. So what do the urodynamics tell us for these three people? It might tell us if John is safe using a convene or whether he really does need to have a catheter put in. It might tell us why Jane is incontinent and what would be the best procedure for her to improve this. Perhaps it tells us that Laura is incontinent between her catheters and why that is, and therefore what we could do about it. And again, we can bring this back to our aims. The urodynamics are helping us to protect the kidneys. They're helping us to address social continence and people's symptoms, and as a result, helping us to maintain people's quality of life. So let's move on to cystoscopy. So I often hear people say when they're performing a cystoscopy in the clinic, I'm going to look into your bladder with a little telescope. And I often think, gosh, I would be a bit terrified if that was me having a telescope put into my bladder. But it is a very small thin tube, a little bit like a catheter. When we perform this in the outpatient clinic with you awake, and it enables us to look up into the bladder and examine what's going on inside. If you are at risk of autonomic dysreflexia, then this might be something that's done under general anaesthetic in the theatre. And sometimes in that setting, we will use a slightly bigger, more rigid telescope, which gives us a better view because of being under anaesthetic. Why might we perform this test to have a look into the bladder? It might be to investigate blood in the urine or to have a look if there are lots of recurrent urine infections that we can't explain. It might help us to diagnose a bladder stone, or in some circumstances to give some bladder Botox injections, and my colleague Ian will come on to talk about that a bit later on. It may also help us to identify or diagnose a bladder cancer in somebody who's been having symptoms suggestive of that. So who needs a cystoscopy? Now, I might say that none of these patients really need a cystoscopy. And that comes back to being really sure that we need to do these tests in order to gain information. And there isn't any information we have here on these patients that would say to me, oh, they definitely need to have a cystoscopy. However, we could speculate a bit further, and perhaps John has had lots and lots of catheter blockages. It's maybe hard to change his catheter, and so we're a bit suspicious for a bladder stone. Perhaps he's had some blood in the urine and we're worried about where that's coming from. And those would be reasons to do a cystoscopy. Perhaps Jane has got a very squeezy, overactive bladder and we decide to manage that with some Botox injections. And she comes to clinic for a flexible cystoscopy and Botox to manage her incontinence. Perhaps Laura has undergone a procedure to help manage her bladder, and she's had some complications, and that means we need to have a little look in with a telescope to identify what is going on. So what about bladder cancer? I think this is a common question that comes up, and it's a really difficult thing to talk about with your urologist or your spinal injuries physician. But the truth is with a spinal cord injury, are you at risk? And the answer is yes. And unfortunately, people with a spinal cord injury are up to 28 times more likely to develop a bladder cancer than the general population. And there are a number of reasons for this. Long-term catheters, poor emptying, irritation from bladder stones or infections, all can contribute to that risk of bladder cancer because of chronic irritation. And unfortunately, up to 50% of those bladder cancers in people with a spinal cord injury can be a more aggressive form called squamous cell carcinoma. Now, there are no formal guidelines for surveillance, and this is largely done on symptom basis. So if you feel that there has been excessive catheter debris or blockages or new recurrent UTIs that are not explained, and most importantly, persistent blood in the urine, then this would be an indication to do a cystoscopy to ensure that it isn't a bladder cancer that's causing these symptoms. An ultrasound of your urinary tract can be helpful, although it can be quite difficult to visualize the bladder. So again, we come back to our aims of treatment, and we can see here that again, we're trying to prevent and treat UTIs, manage symptoms, and maintain quality of life. So now I come on to imaging. Now, in many people with a spinal cord injury, it's important to monitor or survey the kidneys because of this risk of pressure on the kidneys due to pressure in the bladder. It's also important to look for stones and to look for problems within the bladder. Now, your urologist or your spinal injuries physician may do this with an ultrasound or with a CT scan. What are they looking for? They're looking for swelling in the kidneys caused by pressure. They're looking for kidney stones, and people with a higher spinal cord injury, particularly in tetraplegia, are more at risk of the development of kidney stones. And they're looking for bladder stones, which are increased risk in poor bladders that empty poorly, and for patients who have a long-term catheter. Now, how often should we do this? NICE have some recommendations where they say those who are at risk of kidney complications should have an ultrasound surveillance roughly every 1 to 2 years. And this would include many people with a spinal cord injury. So who in our case studies needs an ultrasound scan? So John has a high spinal cord injury. He is at risk of pressure in the kidneys, and therefore he should expect to have an ultrasound at regular intervals. Jane, again, we don't completely understand her diagnosis here from the information provided, and she may also benefit from a regular ultrasound scan. But particularly if she developed symptoms of a urinary tract infection or possible stones, this would be another indication. And then Laura, as Sheila alluded to, there are many possibilities as to what her bladder could look like, and it would depend a lot on her urodynamic findings. So again, you can see that your urologist might choose to do a regular ultrasound. They might decide to do a CT scan if they're concerned that you might have stones in your kidney as a result of the results of the ultrasound scan. And again, this is looking at protecting your kidneys, managing your symptoms, preventing UTIs, and overall maintaining your quality of life. So let's briefly come on to bladder management. Now, my colleague Ian is going to expand on this a lot more and talk about surgical interventions. But there are sort of 4 broad categories to bladder management in spinal cord injury. You might use a convene sheath and pass urine with control when you want to into the convene sheath. You might also sit on the toilet or stand over the toilet and wee relatively normally. And sometimes this is as a result of a squeeze in your bladder, and we might call that reflex voiding. Even if you do wee normally, you do often still require some follow-up to ensure that there aren't any complications developing as a result of this. We then have contained incontinence. And as I said earlier, different people have different tolerance of levels of incontinence, and some people will be very happy managing incontinence with pads or a convene. It's minimally invasive, but again, probably does require careful follow-up. We often say that intermittent self-catheterization is our gold standard, and if you have good hand function and you are able to do this, it's a really good way of managing your neuropathic bladder. It involves passing a catheter several times a day to empty the urine from the bladder. It does give you a degree of independence and makes you free of a device, but there may need to be some need for medications or Botox injections to support this approach. And then finally, there's a permanent catheter, and that might sit through the tummy wall as a suprapubic catheter or through the water pipe as a urethral catheter. These are some pictures of those different sorts of catheters and where they sit in the body. You can see the suprapubic catheter on the left and the urethral catheter sitting through the water pipe into the bladder on the right. And at the bottom there are a selection of different intermittent catheters. Now, this is a flip flow tap, and I'm probably a bit evangelical about the flip flow tap. For some people, having a permanent catheter is the best way of managing their bladder. But urologists will encourage you to use that flip flow tap because it ensures that your bladder fills and empties wherever possible, a bit like a normal bladder. If the catheter just drains freely, the bladder can become much smaller over time, and this can lead to other problems. So if you have the hand function and the ability to use a flip flow tap and you're not using one, please do talk to your spinal physician or to your urologist about how that could be introduced. So again, you can see that our aim here with managing the bladder is to protect the kidneys, to manage your symptoms and ensure that you are as continent as possible, to prevent and treat urinary tract infections, and all of these things contribute to maintaining your quality of life. So that's the end of my talk, and I'm going to hand over to Ian Beckley, who is a consultant neurourologist like myself and Sheila, and he works at Pinderfields Hospital, and he's going to talk to you about the surgical management of bladder in spinal cord injury.
Ian, you're on mute.
I've unmuted myself now. I'm hoping that you can see my presentation. Is that correct?
We can, yes.
Excellent. Okay. So as Katie said, my name's Ian Beckley. I'm a consultant neurourologist from Pinderfields Hospital and the Spinal Injuries Unit in Wakefield. And I'm going to talk to you about the medical and surgical management of the common bladder problems. And I'm going to use the cases that we've discussed before. So I'm just having problems getting my slides to move. There we go. So I'm going to talk about overactive bladder. I'm not going to talk about stress incontinence, as these are the most common types of bladder problems that we encounter in terms of continence. I'm going to talk very briefly about catheters, although I know Katie's done that and I don't really have a lot to add to what Katie said. I'm going to talk about some of the surgical operations that we do, and I'm going to do a very small amount on some of the big operations, such as removing the bladder and forming what's called a urostomy. So if we think about our patients, the first lady we discussed was Jane. She's a 45-year-old lady with cauda equina. She has good mobility, so she can walk, has good hand function, but she does have that hidden disability of significant problems with the bladder and her bowels as well. Now, we've not talked in detail about her workup, but I suspect that she most likely has overactive bladder because of the nature of her neurology. It's the commonest thing that we see in patients with cauda equina. And as Katie said, the management for most patients will always start off with some conservative management. And we'll use the frequency volume chart to assess what she's drinking, when she's drinking, how much she's drinking, and the types of things that she's drinking. So we know that coffee and alcohol can cause significant irritation to the bladder, make you go more frequently. And there's good evidence that reducing the amount of caffeine, the amount of alcohol that you drink, can have a significant impact on your bladder function. If those conservative measures don't work, the next thing to try is medication. And if those tablets and conservative measures don't help, then we start to think about surgical intervention. And surgery starts off with simple things like Botox, but can progress to more complicated procedures such as sacral neuromodulation and cystoplasty. Now, I'm not going to talk about either of those last two treatments in any detail, but if you want to ask questions about them in the Q&A section later, then I'll be happy to answer some questions. So if we think about what the NICE guidelines tell us about the antimuscarinic drugs, so these are very common medications that I'm sure many of you will be using. They include things like solifenacin, oxybutynin, tolterodine, fesoterodine, and these are antimuscarinics or anticholinergics, as they're sometimes referred to. And the way that they work is they block the release of a chemical that causes the bladder muscle to contract. So by blocking the bladder contractions that are occurring when they shouldn't be, we can improve frequency, urgency, and some incontinence as well. They've been in use since the 1970s. They're very effective, but they do come with a long list of side effects, and they're outlined in this slide here. So that, as you can see, they can affect many parts of the body. They can cause dry mouth, which is the most common thing that people complain of, and then they have to drink more to treat their dry mouth, and that can sometimes exacerbate their urinary symptoms. It's also important to note that they can impact the way that the bladder empties. And some patients who normally manage their bladder by going and standing and weeing in the toilet, or sitting and weeing in the toilet, if they start using these medications, then you can impair the bladder's ability to empty in that way. And you may need to introduce catheterization at the expense of getting a little bit drier. The other thing to be aware of is that there are some studies that suggest that long-term use of these medications can be associated with problems with your memory and things like that in the future. So if you are having significant problems with these medications, it's important that you talk to your GP or your urologist about them, and then you can think about maybe switching to an alternative. The most common drug that we'd use instead of an anticholinergic would be something like mirabegron. It's a different type of drug. It works in a different way. It works by relaxing the bladder. So it allows the bladder to heal, to hold more urine, and reduces the urgency and the frequency, and hopefully incontinence episodes as well. It's been around for about 10 years now. And when it first came on the market, some of the studies showed that taking a tablet could slightly increase the blood pressure for some patients. And so if you're somebody with a high spinal cord injury who's at risk of autonomic dysreflexia, then we had some concerns about the safety of using this drug. But fortunately, there's now a newer tablet called Viabegron, which is a similar class to mirabegron. It works on the same part of the bladder, but it doesn't have any adverse effects on the blood pressure, so it's quite safe to use. So if medication fails, and as Katie suggested, then we may need to use Botox injections in the bladder instead. There's the same stuff that people like to inject into their faces to relax their wrinkles. And the way it works in the bladder is it stops those abnormal contractions that can cause incontinence. That can also cause urgency and going frequently. Now, it doesn't last forever, sadly, and most people would expect to come and have the treatment done once or twice a year. But when it does work, it works incredibly well. And we'd expect 7 or 8 out of 10 patients to have a significant improvement in their bladder control when they're using Botox. But the trade-off to that is that it will sometimes work so well that you can't empty your bladder by going and passing urine normally, if that's something that you were doing before. So there's a high chance that you may need to use either an intermittent or a permanent indwelling catheter if you're going to have Botox. So the way it's done, as Katie suggested, is using a telescope or a cystoscopy, and we pass the telescope through the water pipe into the bladder, and then we pass a small needle through the telescope and inject the bladder in either 10 or 20 locations, depending on how much Botox we're given, and generally the surgeon's sort of preference and how well you tolerate it. Most people can have it done under a local anaesthetic, and on the right-hand side you can see a picture of the view of the Botox swelling as we inject it into the bladder. But some patients need to have it done under a general anaesthetic. And the difficulty with requiring it under a general anaesthetic is that we don't have as good access to waiting lists for these procedures. Now, we know that Botox wears off, and it's really important that when your Botox wears off, you're able to get treatment again very quickly. And that can be a little bit difficult, particularly if you have to have it under a general anaesthetic. So it's really important that if you are using Botox, whether that's to improve overactivity or to stop a bypassing leaking suprapubic catheter, but if you're having Botox in the bladder for any reason, as soon as your symptoms start to wear off, you need to get in touch with us so we can get you back on the waiting list as soon as possible to have repeat treatment. So moving on to the next patient, Laura, who has flaccid paralysis from transverse myelitis. Now, she's likely to have stress incontinence due to the pattern of her neurology. And for that, we'll take a similar approach of conservative measures. And the most important is to try and make sure that she's emptying her bladder completely. And we'll do that using a bladder scan or an ultrasound scan just to see how well she's emptying. And it may be that we need to introduce an extra catheter to her daily regime, because if the bladder's not emptying completely, she's more likely to leak when she transfers or coughs and strains. There are other conservative measures that we can use, particularly things like helping with weight loss, and pelvic floor physiotherapy may have a role for some patients, obviously depending on the level of their spinal cord injury and their degree of function. If conservative measures don't work, then we do need to think about surgical interventions, but it's really important for surgery and stress incontinence that we're doing a really complete assessment using videodynamic studies, as Katie talked about, because what we want to make sure is that if we're doing an operation that stops the bladder from leaking, we're not going to create a system where the pressure is high in the bladder and that starts to cause back pressure and make the kidneys more swollen and eventually stop working. In terms of the operations for stress incontinence, there are 4 commonly used ones, but I'm really going to talk mainly about the 2 that we use, which is an autologous sling, or sometimes called a pubovaginal sling, and the artificial urinary sphincter. So an autologous sling is a sling made from tissues from your own body. And we commonly, as urologists, take something called the rectus fascia, which is a strip of tissue from your tummy muscles. It's some tough tissue that sits over your six-pack muscles. So we make a small incision at the bottom of the tummy, and we take a strip of this tissue, and then we make another incision in the vagina in front of the water pipe, and then we pass the sling underneath the water pipe, and then there's 2 sutures on the end of the string which we use to tie it tight. So we create a sort of circle, a supportive band to reinforce the water pipe, and sometimes we can tie it really tight to significantly reduce the leakage from the water pipe and to improve the stress incontinence. It's a very effective operation. We'd expect 8 or 9 out of 10 people to be either completely dry or significantly drier after having this procedure. But it does mean that you're very unlikely to be able to pass urine normally, and so you need to empty the bladder either with a permanent indwelling catheter or by using disposable intermittent self-catheterization. The other option for surgery is the artificial urinary sphincter. Now, this is not done quite as commonly as the pubovaginal sling, but it's very, very effective. In fact, it's the gold standard for stress incontinence surgery. The sphincter itself comes in 3 components, which you can see in the picture. There's a cuff that sits around the bladder neck and the water pipe. There's a balloon that sits inside the tummy, and there's a pump which normally sits inside the labia, the vaginal lips. It will sit on one side or the other. So when you're sitting at rest, the cuff has got fluid, it's filled with fluid, and it's causing pressure on the water pipe to allow the bladder to fill and to not leak when you cough or strain or transfer. Then when you want to pass urine or to empty the bladder, you squeeze the pump that's in the labia, and that moves the fluid from the cuff into the balloon and allows the pressure to be released so that you can empty the bladder. And then when you finish, the balloon pushes the fluid back to fill the cuff up again. So it's a very straightforward, simple system, but it's very effective in improving continence. But again, it's really important to understand that once you have these operations, you won't be able to empty the bladder, and you will need to do intermittent self-catheterization or have a catheter in to empty the bladder. We tend not to use suprapubic catheters with sphincters because there's a significant risk of infection, and if the artificial sphincter becomes infected, it would need to be removed. Finally, we're going to talk about John, who is the tetraplegic chap who's been using a convene sheath for the last 20 years, but is now getting recurrent urinary tract infections. So he would need a full workup with urodynamic studies to try and establish exactly what was going on. But it's likely that after 20 years, his bladder's not contracting as well as it did when he first started using the convene. And for that reason, he's likely to need to have his bladder empty. Now, if he has really good carer support, then he could use intermittent self-catheterization, as at his level of injury, he's not going to be able to do it himself. But if not, then he needs to think about having a catheter either ureterally or as a suprapubic catheter. And our preference is always to use a suprapubic catheter because it allows that separation between sexual and urinary function, and it also prevents damage to the water pipe from an indwelling urethral catheter. And I'm not really going to say any more because I thought Katie gave a fantastic explanation of why we like suprapubic catheters and how patients can benefit from using a flip flow valve. Finally, If all else fails, there is always the option to use major surgery to remove the bladder and to connect the water pipes from the kidney to a tube of bowel inside the abdomen and to bring that out as a stoma. And that's called a urostomy or an ileal conduit. It's not something that we do commonly, but it is an option that we can offer in appropriate patients if everything else has been unsuccessful. So, to summarise, whilst bowel and bladder problems are unfortunately part and parcel of having a spinal cord injury, it's not something that you need to accept if you're having incontinence, and you should always seek help with these problems from your local urologist or your GP. But if they're not able to help you, then as per all of the guidelines that we talked about, you should insist on referral to a specialist neurourologist. The principles of how we'll help you involve taking a detailed history, doing some tests, and then starting off with simple conservative measures and medical treatments. But if they're not successful, then we will offer you some form of surgical intervention. And that may be a small operation like Botox, or it may be something more invasive like an artificial sphincter or a sling or even a urostomy. But whatever we do will be in full consultation with you, and we'll decide together with you which operation you require, where you're going to have it done, and when you're going to have it done. That's all I was going to say. I'm now going to pass over to my colleague Merash, who's going to talk about that horrible problem that lots of patients face, which is recurrent urinary tract infections.
Thank you very much, Ian. Fantastic talk. I'll just start to share my screen. If somebody has to say yes if you can see my screen.
We can, yes.
Fantastic. So I'm really thankful to all the colleagues who have laid a fantastic foundation for my talk. So my talk would be will flow in very easily with the topic. So as Ian said, my name is Mevish, and I am a consultant urologist, and I'm a complex UTI lead at James Cook University Hospital that has a Golden Jubilee spinal injury unit as well. So why we're talking about the urinary tract infection, specifically in the context of spinal injury. So we know it is a big problem worldwide in all general population, but the spinal injury patient, due to their neurogenic bladder, they are at high risk. The risk is as high as 20%. But if we split it down, and you can see the difference if we compare from a spina bifida, where 50% of the children get the UTI in the first 15 months, and then 44% will have more than 5 UTIs by the age of 15. In spinal injury patients, 31% of the patients are diagnosed with urinary tract infections in the first year of a spinal injury, and 21% of those can get hospitalized due to urosepsis. So it's quite a big problem. And this does not end here. These infections, if they remain untreated or they are poorly treated, it can lead to damage to the kidney, as we call it, renal scarring. It can affect up to 40% of the patient, and if remain untreated, it can result in the loss of the kidney function and leads to end-stage renal disease. We spoke about the urosepsis, and that can lead to, if untreated, it can lead to a mortality, which is a death in 10 to 15% of the patients. So UTI in spinal injury patients can be a bigger problem if we compare to a general population. So why it is a problem? It is a problem because there are several contributing factors. The neuropathic bladder, or the bladder in a spinal injury patient, has altered bladder mechanics. It does not wash out as it would usually in a non-neuropath. There is a risk of urine going back up into the kidney because of the high bladder pressures. And then the introduction of the catheter in this whole equation makes it more complex. So there are theories that because of the catheter, not only that the catheter itself is a foreign body, it can also lead to damage to the layer of the bladder. And the bladder layers can also result in some biofilm formation and risk of stone formation. So what are the risks? So the high-risk complications in neuropaths happen because the symptoms may not be exactly what you see in general population. The symptoms as well as the signs are different. So in the spinal injury patient, the symptoms can vary depending on what is the level of the injury. It can present simply as abdominal pain, back pain, pain during catheterization, fever, and the most dreadful worry for us as an autonomic dysreflexia, which obviously needs to be treated as an emergency. The signs could be the cloudy urine, smelly urine, some blood in urine, which Katie has already alluded to. But another bigger problem is that you don't have the usual organisms in the urine, which is E. coli. So E. coli is the most common ones, but when it comes to the spinal injury patient, although E. coli is most common, but they also have different other bacteria that may not be covered with usual antibiotics, which mean if we treat them without a proper culture, which tells us which antibiotic should be given, and we end up giving them a usual antibiotic that may not be useful, but also there's a risk of developing what we call as resistant to the antibiotic. And that actually shows you the growing problem of developing antibiotic resistance, because if we don't treat this problem now carefully, that will become a bigger problem, which means at one point we don't have any antibiotic to prescribe. And hence the GERV guidelines, which is getting it right first time, it says that the patients should be provided a holistic care in a multidisciplinary setting. What it essentially means that depending on whatever clinical needs patient has, it may be a urologist, a spinal injury nurse, a GP prescribing the antibiotic, a pharmacist who look at the overall prescription. So input from wherever they need, and it should be a personalized care plan for the patient. It will help to reduce the clinic visit, optimize the use of antibiotic, and hence we can take care of the risk of the multi-drug resistant infections. And these are some of the links of the NICE guidelines that you can look at. This is available on the public domain, which is on the recurrent UTI treatment with antibiotics, as well as the antibiotic prescription in patients with the catheter-associated infections. I won't go too much in detail about the UTI worker because Katie has already done a marvelous job of explaining all of this in detail. So what do we need as a baseline? It will include an ultrasound to look at, is there any scarring? Is there any damage that has been done because of UTI? Is there any obvious cause, such as a stone, any swelling in the kidney, a telescope test, which we have heard about before, and urodynamic tests to ensure that the bladder pressure are not too high, because the risk is not only that it can affect the kidney in one way, but also if the bladder pressures are high, it can transfer the infection from the bladder up to the kidney, which is called as pyelonephritis, which will become a bigger problem if remain untreated. So what are the strategies to prevent? So as we say, we have to evaluate if this becomes a persistent problem. We have to identify if there is a hostile bladder. So we do video tests called as video dynamics. We have to look at the bladder management and the storage safety, and it depends on patient's needs. It's a personalized evaluation where we see if the patient is able to pass urine, do they need a catheter, do they need Botox, anything that can bring the bladder pressure to a level that is safe. The focus is on preventing the infections rather than doing a reactive treatment. So we'll look at the prophylactic measures in a minute, but if we look at the broader variety of options we have, for females, there's an option of a vaginal estrogen cream that I'll talk about, then cranberry, methenamine hippurate, D-mannose, prophylactic antibiotic, and up-and-coming vaccine option as well. But the one thing is really important, that if the patient suffers with recurrent infection, they need surveillance in the form of at least annual ultrasound scan, but it is depending on the clinician discretion. And if you have a concern, you can speak to your urologist about it. We heard about the catheter management. It's a belief that when you leave the catheter in through the urethra, there is a higher risk of infection. And if you compare that with those who are doing intermittent catheter, compared to those who are using sheath catheter, and compared to those who have got suprapubic catheter. So those obviously who are passing urine normally with the normal pressure, they have the least possible risk compared to those who have got the catheter through the urethra, has got the highest risk of infection. But we have to also consider that these studies have limited number of patients, which means the groups were not equal. So the bladder care would be individualized. There's a discussion of different type of catheters. Some patients might experience increased infections with introduction of catheter, in which case, if the catheter is a requirement and patient definitely need a catheter, we can think about, do they need a suprapubic catheter? If they're doing intermittent catheter and do not want a suprapubic catheter, we can look at different types. And if you speak to your specialist nurse, they would be able to help you find a better match of what is more helpful for you. So there are different type of coatings, some antibiotic impregnated catheters. And you can also discuss about the option of using some solutions to wash out the catheter. If you look at the NICE website, there are about 14 to 16 type of different solutions that can be used to wash out the catheter. And there's some evidence, which is very recent, that shows that these washouts do prevent blockages and does not increase the risk of UTI. So at least this intervention of washout will help with the catheter blocks. So the female patients with spinal injury will also benefit with vaginal estrogen cream if they are of age in the perimenopause or menopause. And we also have to consider those who have surgical menopause for whatever reasons. They could be a young patient, but their ovaries are not working. If they have got other symptoms, even if they are on systemic HRT, they are still okay to take topical vaginal estrogen cream. It is a safe option. It works not only for infections, but also the vaginal irritation, pain during the intercourse. So it's worth discussing with your GP if you want to explore this option. Cranberry, which is again a safe product to use. This, what basically it does, it inhibits the bacteria to cling onto the bladder surface and prevent the infection that way. It reduces the risk of infection up to 30%. The safety profile is very acceptable, and hence if the patient is getting benefit, they can use cranberry over the counter, so it's easily available. Same goes for D-mannose. It's a monosaccharide. It also does the same job. It prevents the bacteria to cling onto the bladder surface, and we have good evidence that it has got a safe profile to use. It's well tolerated, does not give many side effects, and it may be helpful as an adjuvant treatment. So all of these treatment I'm talking about, they are preventative measures. They are not for treatment of the active infection. One up and coming, you know that it is now NICE approved medication. It is called as methenamine hippurate, famously known as Hiprax tablet. They are big tablets, but what is really good about these medications, they are not antibiotic. They are, sorry, they're antiseptic medication. And what it does, it hydrolyzes into formaldehyde, and it works best in acidic urine. So sometimes you will hear your doctor is saying you to take vitamin C with this Hiprax tablets. They work really well, and we have enough data to suggest that it is non-inferior, which means they are almost comparable to the antibiotic preventive dose. So there is always a discussion, if you go back to the slides, is it safe to take Hiprax tablet long-term? If you are having really good response, your infections are controlled, it is entirely safe to take Hiprax tablet. There's a small group of patients because of some other medical problems they may have. They may need some blood monitoring, but in generally, if you don't have any other issue going on, Hiprax tablet are very safe to take in long term. If all else fails, sometimes we have to make a compromise and say that we have to leave the patient on antibiotic prophylaxis, which means a tiny dose of antibiotic that is given as a continuous measure, and that keeps the infection at bay and prevent infections. So it has to be an individualized decision, and we have to consider all options before we go to the point of putting a patient on low-dose antibiotic. At times, what you need to do to start off with this, and as the infections are well controlled, then you can think about non-antibiotic options. So judicious use and careful counseling is the key, because some of the antibiotic, if used in long term, can cause harm. And that means it's really important that you have an open discussion with your clinician about it. But it is certainly an option if you get a good response with this. There's another thing which is becoming increasingly popular. We have got good data, which is the bladder washout, or instilling the antibiotic as well as non-antibiotics within the bladder to target the bacteria where they're actually growing. If we talk about the non-antibiotic option first, which is the glycosaminoglycans replacement therapy, what essentially it means that when there is an invasion of the bacteria or inflammation or anything that happens to the bladder wall, there's a theory that the bladder wall get disrupted, which makes it easier for the bacteria to cling onto its surface and causes what we call as a chronic UTI and pain in the bladder. When we instill this GAC therapy within the bladder, it helps the bladder wall to replenish, which means it will close down the bladder wall and create a barrier between the bacteria and the inner surface of the bladder, and then prevent the inflammation process and infection in the patient. So it has got some role in the prevention. The other thing is antibiotic installation directly into the bladder. And the concept is just like when you have infection within your eye, your ear, you put antibiotic directly where the infection is rather than take a systemic antibiotic. So what we have looked at putting the antibiotic directly into the bladder. And what we do is we teach the patient to put the antibiotic through a temporary catheter into the bladder themselves. Our specialist nurse teach them how to do it, and they do all the treatment at home, which means it will prevent the need of coming to the hospital regularly, and patients manage these treatment really well. The good thing about it is that it targets some of the bacteria which we are unable to otherwise treat with oral antibiotic, which means it prevents the hospital admission. We specifically look at the neuropaths, and we had really good results even in these complex infections. And you can see it reduces the risk of the resistance of bacteria as well from 44% to 10%. And patients report really good response, not only to the infections, but also feeling better with this treatment. There's some role of UTI vaccines. So if somebody's getting bacterial infection, which is sensitive to most antibiotics, then vaccine could be an option. However, there's limited availability on NHS. It's quite controlled, and we're hoping it will be available for a wider population. But at the minute, its availability is limited, and we have very limited data in spinal injury patients. So if I have to summarize, when you're managing the UTI, a urinary tract infection, we have to first check, are we really dealing with a urinary tract infection, or is it just a cloudy or smelly urine? We have to look at overall patient symptoms, and we have to look if there is any modifiable risk factor or anything that we are missing, such as catheter type, stone, so on and so forth. And we have to investigate if it has not been investigated recently. We have to optimize the bladder management, and we have to focus on the preventative measures in order to reduce the antibiotic needs. But having said that, when we have to prescribe the antibiotic to treat the active infection, we have to prescribe it, and it should be guided by a properly done urine culture. And we have to seek the MDT approach, which essentially means getting input from the urology team, spinal injury team, as well as the microbiology, and involving the patient itself to get the personalized care plan for the patient in order to prevent any further infections. So that's all from me. Thank you very much. We'll take the questions at the end.
Thank you, Miwash. I'll just share my slides.
Yeah, so I'll pass it on to Mel Williams from the team now. Thank you.
Thank you. Thank you. Okay, can everyone see my slides?
We can, Mel, yes.
Lovely, thank you. And thank you, first of all, to Sheila, Katie, Ian and Miwash. Really good presentations, really enjoyed listening to all the clinicians talking this evening, so thank you very much. So my name's Mel Williams. I am the spinal cord injury specialist nurse for the South West region, and here this evening to give you a little insight into how the specialist clinicians in the SIA team can help support you. Just a bit of background. Has my slide moved forward? Yes, okay, so just a bit of background to start with. So we recognise that life expectancy for people with spinal cord injury has improved significantly over the years due to medical advances and better quality of care. Listening to members in our SIA focus groups and receiving feedback from our peer support officers, who are now called support network coordinators, we recognised that we were being asked more clinical type questions. And from listening to the feedback, the SIA started in 2016, the specialist nurse service began with 2 nurses, Carol Adcock, who has spent many years working in the North West Regional Spinal Injuries Centre at Southport, and Debbie Green, who spent also many years working in the National Spinal Injuries Centre, Stoke Mandeville, our 2 founding members. So since 2016, the team has tripled in size to 5 nurses and an occupational therapist, and the specialist clinicians cover England, Wales and Northern Ireland. So a bit more about our team. So, as I said, we are 5 specialist nurses and a specialist occupational therapist, all with many years of spinal cord injury knowledge between us. We all have our individual catchment areas, which I'll go into a bit later, which together cover the UK, excluding Scotland. We don't cover Scotland as they have their own spinal injuries charity. So we provide support for people with a spinal cord injury and their relatives. We also are an expert resource for professionals working with people who have a spinal cord injury. We also provide training and education in the care and management of spinal cord injury to healthcare professionals from all healthcare settings. And what our support looks like, and you'll see in a minute, the large areas that we cover, is a lot of telephone support backed up with emails, sharing information, using the information we have on our SIA website. We can do video calls. We can also offer in-person visits. We can attend meetings and MDTs, anything to fit around what the member requires in terms to support them. In the last financial year, we actually supported 1,381 members over 3,205 sessions. So this is a map of visual representation of our catchment areas. And I'll just work my way through the map here. So we have Carol Adcock here in the northwest, Susie Wood in the northeast, Karen Biggs who covers the Midlands, Debbie Green who covers the east of England, Mark Jarrett who covers Greater London, and myself, I cover the southwest of England. If you're not sure which clinician you need to refer to, if you go onto the Spinal Injuries Association website, if you come to this page, there's a drop-down menu where you select your county, and that will specify which clinician you can then refer to. Super easy. So a bit more about what we do in more detail. So we work in various different settings. So in the acute care settings, we are there in hospitals to provide assessment and advice to the clinicians looking after the people who have sustained a spinal cord injury. And this is really providing support and advice not only to the person who sustained an injury and their family, their relatives, but also to the staff looking after them, talking through ways of managing, for example, bowel management, and also things like autonomic dysreflexia, which staff in general hospitals might not have ever come across and might not understand how to manage and treat. In the community, we're there to give advice and support to people with a spinal cord injury, their families and friends, working with community healthcare teams by liaising with relevant healthcare professionals. And we offer support to spinal cord injury patients to increase their confidence and their needs, making sure they're met in the community and during hospital admissions. Another tool we have is the essential care passports, which were previously called emergency care plans. And this is like a roadmap of your care needs, which is formulated by an appointment with yourself and either a specialist nurse or one of our volunteers. It goes through every aspect of your care, so bladder, bowel, skin, and other topics are covered, management of autonomic dysreflexia. Once the content is agreed, you get a copy as a PDF, which is available for any planned or emergency admissions that you may undertake during your journey with a spinal cord injury. So this is how you can refer to our specialist clinician team. The QR code, I believe, is going to be put in the chat for you to use at a later time. We have our support line and also a clinical services link where you can refer to any of our clinicians depending on the area which you live in. And we do take referrals not only from people who've sustained a spinal cord injury themselves, also their relatives, carers, healthcare professionals who are involved in their care. But obviously, if it's not from the person themselves, we would ask that consent is needed if you're going to refer them to us. I must also mention our fantastic support network service coordinators. We work very closely with these members of our team, and I would describe them as a fantastic resource. They're the first and main point of contact for the person who sustained a spinal cord injury and their families and carers. All have a lived experience of spinal cord injury and offer that advice and support, that real lived experience with lots of different topics, sharing knowledge and information, signposting and onwards referrals. We also have the Knowledge Hub, which again is accessible through our website. Lots of really great information and resources here, fact sheets, videos and links separated into 3 distinct topics: body, mind and life. Another fantastic and free resource for you to access. So just going to talk a little bit about the case studies just to finish off my presentation. So looking at John, first of all, so we know that he's a 65-year-old male with tetraplegia and he's managing his bladder with sheath. He is looking at probably an option of changing his bladder management to either an indwelling urethral catheter or a suprapubic catheter. So first steps would be to really contact John, really understand the issues that he's experienced and offer support and provide information if he is considering a catheter as an option. It could be that if it's not a problem with his sheath fitting, it is actually his bladder that's changed. We would always recommend an early referral to urology, getting the GP involved so you have that facility to access those more in-depth investigations such as urodynamics and cystoscopy, as mentioned by Katie. We would involve any community staff that are looking after John, provide training and support, especially around managing someone with a tetraplegia with an indwelling catheter or suprapubic and the risk maybe of autonomic dysreflexia and things and ways to manage that. So really wrapping around John and giving him the information to make an informed decision alongside his clinicians, but also educating community staff and maybe bringing in a physio and OT if needed to look at his home setup. Case study 2, we have Jane. So as we know, she has an L5-S1 disc and cauda equina. She has this, she's very incontinent of urines and feces. So the first step for me would be to understand with her bladder, what is happening with her bladder, with that in-depth assessment, as mentioned by colleagues earlier in the presentations today. Once we have an understanding of how a bladder works, then there can be decisions made about how to help manage a bladder in the longer term. And if that is, for example, to manage with the catheter exam, we can refer her to community services such as a continence service, or maybe a company nurse who can visit her at home to teach her the technique. Because she has a cauda equina, we could work very closely with other charities. We could refer her to the cauda equina charity for more support. Get the involvement of a local support network coordinator and maybe involve our SIA counselling service, because these symptoms are really distressing for people to live with, and maybe in time she would benefit from support and talking about the problems that she's experiencing and really come to terms with how to manage them. We also have a fantastic resource, community groups, which she may wish to access in time, obviously when her to speak to like-minded others who have a spinal cord injury and really getting that support from others who have been maybe in a similar experience to her, similar place to her. And lastly, Laura. So she is a 24-year-old female with managing her bladder with ISC or suprapubic catheter. Again, first steps would be looking at contacting to provide support and information to her, really getting an understanding of where she is currently and how she's managing, providing community staff support and awareness, again, about the care needs of a person living with a spinal cord injury who has a catheter, getting that local support network coordinator involved. And if she wanted to, if she's not able to get out of the house, and also for case study 2, this is relevant, we could get the support of the Travel with Confidence team, who've developed a fantastic resource to enable people to access the outside world, to get on a bus, to get to a clinic appointment, to get to community groups. Again, a brilliant resource that we have available for members. The last thing to say is that we don't have any limit on our support and phone call appointments, so we can continue to support a member and their families for as long as needed, and we're here to help, so please do get in touch. Thank you very much. Over to you, Karen.
Thank you so much. Thank you to all of our speakers, but we're gonna come back to the speakers in in just a little while. Before we do that, I'm delighted to welcome Ian, who is one of our trustees and somebody who's been living with a spinal cord injury for some time. So bringing in the lived experience. And Ian, we caught up earlier in the week, and we had a very kind of fantastic lengthy conversation. I'm not quite sure how we're going to manage to fit kind of an hour into 20 minutes of some of the discussion that we had. But, first of all, please introduce yourself. Tell us a little bit about, who you are, how long you've been living with your injury, and just a little bit about you in the first sense.
Hey, Karen. Yeah, so I managed to break my neck as a teenager in the late 90s, and probably many of you will be thinking, there's something wrong with my camera. That guy can't be that old, but I am. And so I've got almost 30 years worth of experience. And I think over the time, I filled out my bingo card when it comes to urology, and starting off with kind of convenes and convene drainage. And I remember being in hospital as a sort of young man, and after I would kind of go for a wee, then it was like a catheter was done to check how much urine was left behind. And I personally really didn't, not that anyone would enjoy that time in hospital, but I struggled a lot with just the stress of medical procedures. And so I really just wanted to kind of get home. And I didn't really put any meaningful effort into trying to understand everything that was going on with spinal injury. There's so much to take in that it was more just like, how can I, be as independent as I can, and how can I stay dry and try and start to kind of rebuild life in a sense, to be able to get my house in order, so that I could go off and since that time I think I've been to about 80 odd countries around the world. I work full time. I started my own business. I've done a PhD. I'm married. I've got a little baby boy who tires me out. He's almost 3 now. So I live a good full life. But alongside that, I've had a number of challenges over the year when it comes to kind of urology. So.
Yeah, and I mean we're gonna delve into some of those, which is what we're here to talk about a little bit this evening. But I guess one of the things I just wanted to ask before we kind of move on to some of the challenges. I mean, you explained that you were injured as a teenager, and it must have been hard enough to be getting your head around the fact that life had just changed overnight for you. How did you get your head around the bladder side of things?
So I think the bladder side, it's almost like there's so much kind of going on that in the grand scheme of it, it's like, oh, it's just one other thing, because you're sort of dealing with the fact that you now, for me, I'm sort of like a C6 incomplete, a tetra. And I remember at the time, you very rarely, and thankfully will never lose as much from an injury as you do then, because you lose your job, your car, your home. In fact, you can't walk again. Now you've lost your incontinence, and it's just like all of these kind of things happen and they hit you. So it's really just trying to, in a sense, that rebuilding of like a bit at a time. And I suppose my main priority then was to stay dry. And you're thinking like, oh my God, I'm never ever going to be able to, how could you ever have sex again? It's like there's all of these things kind of running through is like that teenage boy mindset. And it was just like, and so I think there was a lot of that. But just that desire to get as good as I could in terms of being independent, taking more control of my destiny was really key.
And you speak about the fact you faced some challenges. Tell us a little bit about your kind of bladder experience and navigating the NHS side of things, because you did mention when we caught up earlier in the week that you get almost this bit of a quirk or a bit of a tingling, and I've heard that others refer to something similar. But tell us a little bit about your bladder experience and how you've gone about it.
I noticed for the first time that I was getting this like weird tingling sensation on the back of my neck, and I was actually in front of a girlfriend at the time, and I weed into one of these little cardboard tubes there, and I didn't know I was going to do it. And I suddenly like connected these things together, and it was like this early warning system, and it was incredibly useful because it gave me about 60 seconds to 30 seconds of like, oh, I'm going to go for a wee in this much time. And that is so useful for being able to then just do a sanity check. Or is my kind of accommodation in a good place? Is the tube, is everything, you know, there? Because that was for them, that was the sort of the priority, is like stay dry. And so it's a very funny thing as you start to kind of listen to your body and you learn these things. It was such a useful thing to know, because I could equally then just check to make sure, oh no, it's still dry, everything's fine, hasn't kind of come off. And because what I will say is the quality of things like commons has changed so much since like the late 90s to compared to kind of what they are now, and I find them to be far more kind of reliable in more recent years. So that's been a big positive.
Absolutely. And you said earlier, and we've spoken at length about some of the challenges that you faced. You know, talk us, as much as you're comfortable, talk us through some of the challenges you face. You've mentioned that you're quite a traveller, and you've been to quite a few countries, and we've actually had some questions that we'll return to about travel later. But talk to us about some of because I know you shared a story with me where you had a particularly challenging time when you were away, but maybe didn't recognise quite at the time how significant it was. Talk us through some of that.
Yeah, so I think I was very lucky when it came to my sort of the urology side for maybe about 20 years. And then I got sort of I was abroad, and I was in China, and in hindsight I must have had a UTI before then. It had been sort of like I'd ignored. I'd never taken antibiotics almost in 20 years, and never gone for anything to do with UTI. Obviously very, very lucky. And then I was getting ill, and I got really ill in China, and I was like in a sort of like a hotel room. But for anyone that's been to China, it's a lot of places you can just get by, and you can just speak English. And in China, it's not really the case there. And so I had some kind of local people in the office that I was working with, but I was like, I need to get home. I was like stuck in bed, and I could only get a flight that was like it was in like about 3 days time. So because it was going to cost thousands because of the so close. And so I thought I'd use like a ton of air miles I'd accrued to fly myself home. And when I basically managed to make it, that adrenaline hit of like arriving at Heathrow and parking myself in front of an air conditioning unit to get in the car, drive home, and get to the kind of the GP, and then find myself on that evening sort of like heading in an ambulance, then sort of thinking maybe the appendix has burst, and then be told, oh, you have severe sepsis. And it was like then, you know, weeks in hospital, being pumped full of bleaching my body. And then I was due to get married just a few weeks after that, so I managed to talk them round to an early sort of like a discharge, so I could go and buy a ring and things like this, and do cake tasting, like who wants to do that? But you know, it was a very tough thing. And really after that point, I think it was a sort of turning point for me, where I was well for a bit, and then I started to get very unwell, and it was really I would almost go to the GP and be prescribed, I'll just take these antibiotics for a week, and then I'd be fine for a week, and then the infection would be straight back, and I'd feeling really sick and couldn't eat food, and back in kind of bed. But it was a time where I was kind of between spinal units, because where I was being treated that one had been closed down, and the other one wasn't sort of fully open. So I was sort of discharged to the local the community, and every time I spoke to someone, it was always like wonderful care, guidance that I needed. But the reality of waiting lists, and it would be like, you've got an emergency appointment with a urologist, it's in 9 months' time. And it's like, well, that's not really an emergency, is it? Because I'll either be in hospital, in which case you'll then treat me, or it won't be an issue at all and it will be gone. And so I find that very, very tough. So I privately paid my old spinal unit to give me urodynamics, so that they could then, because what it turned out was that my bladder was no longer emptying, and that was what was probably causing the UTIs I was getting. And so the advice then was like to do intermittent catheters, and of course I'm a bit too useless to do them. In terms of my hand function is very good, but there's actually a bit more to it than that. you need to be able to know you're about to go for a wee, I find, and I would leak all the time, and then I couldn't pull my trousers up when I'm, say, if I sat on a toilet. I just don't have the physical skills to do that, and so it wasn't practical. So then I ended up having like a urethral catheter fitted for a while, and I remember my son was born, and it's just like wonderful experience. Take the baby home, wife's home, and the next day, the first day, he's been home for 1 day, and I wake up and I've suddenly got a left testicle that's the size of a small mango. I've done this again, there's blood, and then I'm thinking to myself, oh my goodness, I've got some internal bleed, and it's the first time I didn't realize your testicle because it actually swell up like that due to a UTI. And I'm back to a hospital to get blasted with IV antibiotics for as short as possible time as I could to get back home. And then I end up on a sort of like a waiting list at Oswestry where like you need a get a suprapubic catheter. We'll do it for you, shortly. But unfortunately, from where I live, it wasn't possible to be done. So I again, it was a waiting list. It would be almost a year. And the trouble is, it's so hard. So I was like, me personally, if there's a problem, I need it fixed. And this is probably the toughest thing I've had to deal with in my sort of like, it's much, like not walking. I mean, it's different for everyone. You value things differently. For me, the recurrent UTIs, the antibiotic resistance has been the hardest thing I've had to sort of deal with. So I'd got a surgeon who would do it for me. Everything was at a private hospital. An anaesthetist agreed, and then the anaesthetist was ill, and the other anaesthetist came in and they cancelled the day before, and it was just like, so because of autonomic dysreflexia. So my body is one of those. I think my body's a great panicker. So what it means is that whenever they change the catheter, my body will scare everyone because I get autonomic dysreflexia, and my blood pressure will go up into the 230s over 150, and it'll stay there for about an hour. If whenever a catheter's changed, and that meant that I always had to go back to hospital to kind of get them done. And then this, I think, is where you start to collide with NHS guidelines and spinal injuries guidelines. The NHS guidelines say you change that catheter every 12 weeks. That's not really the experience and guidance that I've seen coming from spinal centres. And so you might make these judgments. And the process of some of these things is hard. And I think that people really have to become an advocate for yourself, and you get to educate yourself in this space. Because like when I first got prescribed Hyperex, which is my trusty bottle here, GP refused to do it. So urologist has said, you need this, get your GP to prescribe it. They sent the referral over. The GP was like, we can't prescribe this. So then the urologist had to prescribe it themselves to me, just because of, I think the drug had just been kind of introduced. I mean, the medical experts here would know better, but for me, it has been a useful kind of addition in the sort of the war against UTIs. But I think it's that thing that there is, GP are obviously going to be incredibly so overworked these days. It feels that there is that sort of desire to, I feel to be like, take these antibiotics, go away, come back in a week. Whereas you as an individual, you know your body, and I feel that you need to be very you need to be much smarter, much more educated. And I think that the sessions that we've had tonight have been wonderful to kind of give people that sort of knowledge about how to think about things like UTIs, because I find them personally so mentally draining, is that because when they come back and you're trying to then be like, is this going to keep coming back until I end up in hospital? So I've been admitted like 5-6 times over the last 5 years for IV antibiotics, and it's miserable. And so each time you're like, it's that's what's a mental toll it kind of puts on you, and unpredictability of like, having to kind of cancel things that you plan to do because you're like, oh, I'm going to be ill that week because this is coming back. So it makes it tough.
And you spoke a minute ago about the value of being able to educate yourself and advocate for yourself. I guess, how have you managed that? And become good at that over the years? Because of course, when you sustained your injury, you were kind of teenager, and so you've grown with it. So how have you developed some of those skills to be able to push and advocate for yourself? How do you focus on some of that?
For me personally, and I appreciate what I'll say will be very different for every other individual, but I really want to, when I die, I want to have my memories filled, and I think there's that thing of, you don't really regret the things that you try to do, you regret the things that you didn't try. And so it's been a case for me. I'm very stubborn, and driven in terms of I need my health in order to be able to do these things, and particularly that sort of feeling now with my son, where I'm like, I need to be around so that I can tell him off when he's older doing things as a teenager, and help keep him in line. So I think there's that side, but I would really say that when I was younger, I just didn't care because my health was okay. And then it's that point where things start to change. You then have to sort of really try and educate yourself, because when you go to your GP, which is often your first point of contact, you're an incredibly complex, unique case. Think about how many people with that sort of, every spinal injury is different, and that they don't see kind of many people. The one thing I will say, that autonomic dysreflexia, unfortunately, the reality of it is that it's good and bad in this sense, that I remember I had a blocked catheter. This was a urethral one at the time. I turned up at A&E at like 2 o'clock in the morning, and it was like packed. And then I showed them my phone because I was trying to explain, and I just had a printout. I was like, well, there you are, this is your NHS for what autonomic dysreflexia is. And suddenly you jump through. There's no queue. You are straight through. And you're suddenly feeling like, oh, I'm very important. And then the reality of why you're very important is it hits you. And that kind of gravity, if you're like, oh, this isn't so good. And then, you know, it's like an immediate thing of like, oh, here we do the washout to clear it. And then my blood pressure goes straight back down. And the staff there, because they hadn't really seen it before, they're like, this is crazy, it's incredible. But it's equally, it's terrifying for people who don't see it on that day-to-day basis. So you understanding that yourself, that your body, how that happens for you is really useful, because you can then talk to others and kind of guide them through, I think. So I think you really need to put a bit in fact, and everyone who's joined this call clearly is trying to do that in terms of educating themselves. So it's great to see so many people taking that control of their destiny in that sense.
I mean, what you've just said there is a really lovely takeaway, isn't it? I mean, when you went into A&E, you had something on your phone that you were able to kind of show them and say, this is AD, because sadly, we do know the worrying thing is that there are a lot of kind of frontline healthcare professionals out there that don't understand the full gravity of AD. So I guess by you having that physical thing to show them, I guess it really made them stop in their tracks and understand the severity and gravity of your condition, and possibly how quickly it could deteriorate.
Absolutely. I think that anything like that helps people understand what you're going to encounter, and it's just a simple thing to be able to kind of have that in place and to kind of share that and it really does help, because otherwise I could have sat there and queued for like 8-9 hours with this kind of going on, and so it wouldn't been that wouldn't have been pleasant.
And how are things now? Have things turned a corner? Are things on the improving side with Bladder? How are things?
So for me,
how are things currently?
So I have the suprapubic catheter. I managed to get it kind of fitted in the end. It was one of the hardest things. So it's like I pinned all this hope on it, and I was like, I had it done and I had it fitted, and I had the surgery, and immediately got very, very ill and was back in an ambulance within sort of 48 hours of being discharged, because I picked up a bit of an infection during the surgery and so on. And so that was back in for a few more weeks but having said that, I had a period of time where I was almost like no antibiotics and everything was all good for about 9 months, and then I got a little bit picked up a catheter change and a sort of like a little thing bouncing back sort of like 3 times it kind of came. But overall, I would say for me personally, the suprapubic has been an absolutely wonderful kind of like night and day change. It's not to say it doesn't come with its kind of own challenges, like it's probably oversharing, but people on the call know this stuff. So for me, when I poo, I wee on the floor. It's so irritating. The rest of the time, it's kind of like fine, but I know that there's some things that can be kind of done, but there's different sort of like challenges for me with autonomic dysreflexia and stuff like this that you need to kind of like live with. But it has, you know, it's nice to not, you know, we will worry about different things. Like I travel extensively on flights, and like when there would always be like, oh, is the convene gonna, you know, stay on? And I've actually changed the convene whilst flying in Emirates first class, you know, because it came off, and I managed to put a new one on before weeing everywhere, which was kind of nice, but obviously a bit stressful. A glass of wine to calm the nerves after that one. But the, you know, and then you have the sort of like the suprapubic, where if you have an indwelling catheter in, can be really useful for long haul. But then you've got to kind of manage how much liquid you drink to make sure you stay hydrated and these things. But equally, you've got to be conscious of the fact, well, how am I going to empty the bag? The bag's only so big. Little tricks around that. And so carrying like a night bag in your handbag, hand luggage that you can then empty it into is a useful kind of trick that I've kind of used myself like numerous times. Or an empty bottle, you can discreetly just kind of empty in that sense. You know, there are other things that some people do is like me try and plot shorter flights and routes, but yeah, things are good. So and thanks to, I would like to say that thanks to some of the professionals on this call, gave me a lot of really useful advice as I joined the SIA. So.
Perfect. Great. Thank you. You've actually answered some of the questions that we've received this evening, which has been really helpful. And some of that was around some tips around long haul. So it was nice that you strayed onto that, because I know that you really don't let it stand in the way of travel, which is, you know, is of course what we want to hear. And I'm sure what other people want to hear as well. I'm going to start bringing the other panelists back into the discussion. Just as we do that, Ian, I did have one question. You know, we've heard this evening the talk about increased risks of cancer, and understandably we've had some say it's really scary to hear some of those stats around increased risk. Share a story with me that we spoke about earlier in the week, if you don't mind, just to share that experience, because it was moving for me when we spoke earlier in the week.
So I guess it would be probably about the middle of last year. I'd had blood in the urine, and I told the spinal doctor, and I wasn't particularly kind of worried about it, because you know it happens occasionally. But they were like, we need to get this kind of checked. So contacted the urologist, and then I had the blood test, which is I think the first thing, and then immediately after it, like a CT scan, and then I had the cystoscopy, but the CT scan came back, and they said, actually fine from your bladder's point of view, but we found something on near the prostate, and so you're going to you need to have I think it's called a flexible sigmoid, like a colonoscopy, and I had that kind of done, and I didn't at the time really give it too much thought. I was like, oh, I've got an appointment on a Sunday within a week. Fancy that? That's pretty cool. And so I kind of went in and I had that, and the guy basically who did it said, so it looks like you have cancer, and I was like, oh, okay. You know, it was just like boof. And then he said, but I don't think you do, because it could just be a quirk of the spinal cord injury. And at the time, you feel like I was still sort of like trying to keep just deal with the suprapubic and like recurrent UTIs and that. And then there's this other kind of ton of bricks on you, and see sent away with a form, and you start to kind of look through the form, and you see all these little code words like USC. What does that mean? Google urgent suspected cancer. And you're just like, so I'm going to tell my wife, am I not? Am I going to, you know, do a long 6 weeks wait? They took the biopsies, but thankfully I was, it wasn't that. It was just some kind of like 25 years, I guess, of manual evacuation and some effects that it's kind of had on my body in that way. But what I would say is that whilst it was like obviously not a fun time, at least it got checked, and at least the fact that because I'd attended the appointment and that procedure had highlighted something else. And I think it's that thing of like, there is a temptation to bury one's head in the sand, but the reality is, get this stuff checked, go to your appointments, get these things looked at, and you'll be in a better place for doing that.
Yes, thank you. I really appreciate that. As I said, when I heard you talk about it earlier in the week, you know, it just goes to highlight some of the importance that the others have been speaking about when it comes to scans and making sure you go to those appointments and getting things checked. And, you know, whilst I don't underestimate the kind of worrying period it was for the 6 weeks, but by, you know, that early intervention and early checking would have been important, and in your case, thankfully, it wasn't as serious as it was first thought. So that's fantastic. Thank you. Please stay with us, Ian. We might have some questions. I'm going to start bringing the other panel speakers in so that we can start getting. We've had a huge amount of response this evening from the point of view of questions. I will say Katie has done a fantastic job of answering some of those as the evening's been going on, and giving some guidance on that, which is just brilliant. So we are going to get through as many of them as we can, and I wanted to start because we've had some questions around kind of best practice for swimming, whether we remove day bags, whether or not, you know, how to best protect yourself from not getting an infection when swimming in either pools or the sea, especially when you're abroad and it's in such a hot climate. Who out of our kind of panel experts would like to talk to us a little bit about swimming and kind of best practice around how to manage that? Carol, and yeah, Carol, kick us off, Carol.
I thought I'd best answer this, seeing as I used to be the nurse going with the Great Britain Paralympic swimming team for a number of years.
Great.
I think you've got to the
Atlantic
Paralympics as well with the team. So yeah, it'd be a bit remiss of me if I just sat here quietly. So what some of the people with spinal cord injury or those that had indwelling catheters used to do would be, yes, they would remove their bag and they would use the flip flow tap that we showed earlier in our presentations. But just a word of caution is you do have to be careful, and you need to know that your bladder can hold the urine for the amount of time that you're going to be in the water. Don't just go from having a bag on free drainage, put on a flip flow tap, get into the pool and be there for, you know, an hour or so, because your bladder may not be able to have that capacity, hold that capacity of urine. But that would be the general way that the swimming team used to manage their bladders if they had an indwelling urethral catheter.
Have you got any thoughts on the kind of hot climate and kind of reducing the risk of infection from the point of view of being in the pool and the sea as well? Or did one of the others want to come in and join us on that?
What we would say would a good shower afterwards. You know, if
Yep.
you've been in a pool, make sure that you not only clean yourself, you clean around your urethral area, but you also clean the catheter as well afterwards.
Perfect.
If that's
great.
if it was related to the swimming, yeah.
And then one last question on the swimming, and then I promise I'm going to move on because swimming, it was we want people to be active, so it was quite important. One particular person that's joined us this evening asked about why they notice blood in their urine after swimming.
If that person has an indwelling catheter in, it may be that the catheter is with them being in the water, they're moving in a different way and it's causing trauma. So I'd be a bit, I would look at, is your catheter secure so that it isn't moving and causing trauma? I can't think of any clinical reason. I can see Katie's got her hand up, so I'll let Katie answer that, but that would be my response.
Perfect, thank you. Sheila, let me bring you into the discussion.
Yeah, no, thank you. And first of all, I'm so glad you answered that first at the GB swimming team person. That's amazing. Totally agree with everything you have to say. I think you should be going out there with your suprapubic. Yes, you can swim, all the things you've said. The only thing I would say is that immediately after insertion, I always counsel patients it's like a wound. So just let it heal. I would say wait at least 2 weeks and just wait before you're going out there, as you would with any wound. And the question about the blood in your urine, yes, it's probably the catheter, it's probably rubbing a certain area, but if you've got blood in your urine, you need to ask your urologist, you may need an assessment. So I wouldn't ignore it, even if it's just coming on after swimming. You may need somebody to have a look inside your bladder.
Perfect. That's great. Thank you so much, Sheila, for coming in. And of course, we absolutely want people to take away the message from this evening. If you've got concerns, if you're experiencing certainly situations and symptoms like that, that it's absolutely the best thing to do is to get checked and not to ignore something. We've also had any advice on UTIs when self-catheterizing? I only get them when self-catheterizing. Now, I know that Katie provided some response here, but I don't know if Miłosz, if you want to come in and talk about, because I know you spent your presentation was focused on UTIs. So is there anything you wanted to add when it comes to UTIs or when it comes to self-catheterizing?
Thanks, Karen. Katie has already alluded to that it is a risk factor. So some of the things we can look out for is that do we need to change the type of the catheters? There are different types. And fortunately now NICE actually supports individualized care, which means it is not by cost, it is by the patient need. So you may need to speak to your spinal injury nurse or specialist nurse to see if there's a different type of catheter, because there are some catheter with multiple holes which facilitate the drainage, which means you're not spending too long with the catheter in the bladder. So there is it's plausible that that will help. Essentially, the other thing that can help is taking some non-antibiotics such as Hiprax alongside, because that can also help to prevent the infections. So these are a couple of things that you can do. Other things that I have mentioned, such as the D-mannose, cranberry, you can take all these adjuncts without any problem.
Perfect. That's really helpful. Thank you. And it was just helpful to reiterate some of the bits that you covered during your presentation. So thank you. I guess I'd throw this question to any of the urologists that have joined us this evening, and that's around suffering with constant kind of pain around the bladder, which Chris has been told kind of he's just got to live with. Is there any advice that you would give with regards to that? What how to best manage that? Ian, let me bring you in.
I think it's obviously a really, really difficult thing to manage, because pain is such a subjective thing that often you may have lots of tests which don't show anything. They may look inside your bladder looking for things like stones, not find them, as the bladder looks completely normal. You have a scan that also looks completely normal, but the thing that's constant is that you're having this pain. And depending on the sorts of spinal cord injury, it's quite possible to have neuropathic pain. So it's pain as a result of the spinal cord injury that isn't really related to the bladder, what the bladder's doing. What I generally try with patients is to see if all the other objective tests are normal, then if you can maybe do some urodynamic studies to see if the pain you're experiencing is related to overactive contractions in the bladder, which do sometimes cause pain in some patients. That can be quite easily treated with Botox. Simple things like ensuring that you're using medication to reduce the risk of infections, which can also be painful. There are medicines that we can put into the bladder through a catheter, or you can do yourself through disposable catheters, can help with bladder pain, but it isn't something that you should just have to live with. There's lots of pain medications that can be used. There's a chronic pain specialist to deal with neuropathic pain. And worst case scenario, there is always the option of removing the bladder. It's quite a high risk strategy and doesn't guarantee to get rid of the pain, but for some patients it can be effective. So I would say that if if somebody's saying that, there's nothing they can do, then ask them to refer you to somebody who might be able to offer you something. And if you've got a spinal cord injury, then your neurourologist at your nearest spinal cord injury centre or rehabilitation centre should be able to offer you at least an assessment and some options.
That's great, thank you. Because there sounds like there's quite a few options that can be explored rather than just kind of having to put up with it. So thank you for that. If I could bring Mel or Carol in, we've had a question with regards to the essential care plan. Is there a copy attached to your NHS records, or is it just a physical document? Just wondered if you were to taken into hospital in an emergency, how they would know that there is this kind of plan in place. I'm happy for you to fight it out amongst yourselves, but whoever wants to kick us off.
Shall I answer? So there was actually, thank you, Karen. There was a similar question in the chat. And I think the thing to remember about the essential care plan is it's correct at the time of that it's made. So it could be that you had an old copy attached to your NHS records, and yes, it would be a really important document and would guide clinicians, but it's super important that if anything changes with your spinal cord injury is to make sure that it's updated and correct. So I would say, I don't know if Carol gives a view on this as well, is probably keep it and then share it as necessary, because then it's as up to date as possible. And we don't usually include medications on the ECP for that reason, that they can change over time and it might not always be as up to date as it could be. That's what I would say.
Yeah, and the other thing I would just add is that some people have managed to get an alert put on their electronic patient records to say they have a plan. So and for the staff to ask for the plan. So that's
a really good point.
Do.
Yeah, excellent point, Carol. Well done. Thank you.
Perfect. Thank you. And again, kind of bringing in all of the experts, I guess, for the next question. One of the things that, as an organisation, we're looking to develop is around how people manage their spinal cord injury as they age with it. So one of the questions we've received this evening is, are UTI symptoms different in elderly people? And how do you encourage an elderly person with an SCI to drink more, given they often kind of have a loss of thirst for their age? Carol, thanks.
So some of the ways you can encourage elderly people to take more fluid is in fruit. There's fluid within fruit, so eating fruit. Jellies is another way, encouraging a jelly after it also increases fruit. And there are increases fluid intake within the jelly. But also there are now little jelly cubes that have a really high liquid content that will help with hydration in the elderly. And if you were to, speak to your GP about that, they should be able to access them, to hopefully get them on the NHS if it was a real concern that the person was at risk of dehydration.
Perfect.
Oh, and lolly ices and things like that as well.
Perfect. No, that's brilliant. And Miłosz, if you're still there, do the symptoms tend to differ in elderly people from the point of view of UTIs? I can see you've popped your hand up, so let me bring you back into the conversation.
Great. Thank you, Carol, for alluding on that. So the symptoms can certainly differ. And what we have to look out is what your general baseline norm looks like. And it differs from one person to another. So look out for any unexpected tiredness, fatigue, feeling generally unwell. So if it is not an isolated symptoms, you have to look at overall symptoms. Also, if you're having a foggy brain, that can also be a symptoms, but you have to match it up how your bladder feels. And it is good to seek medical advice sooner rather than later. So we're not saying you necessarily need an antibiotic, but you definitely need some testing at that point. And certainly the symptoms do differ in elderly patients. So yes, I would agree with that.
Perfect. So that's great. Thank you. And Katie, if I may bring you into the conversation, I'm aware I've not directed a question to you just yet, but there was one that kind of specifically stemmed around your presentation. So you spoke about being offered regular monitoring either annually or every 2 years. Do you have any advice on how to access this frequency of care? I know you've put some comments in the chat, but not everyone will have gone into the comments and necessarily seen them. I guess this person is concerned that their spinal unit's not seen them for years, and it feels like they need more regular reviews due to recurrent UTIs, but it's a struggle to get the right level of care. So what would be your top tips?
Yeah, thank you. Yeah, I think this is a really difficult question, isn't it? Particularly in our sort of current NHS climate, which I know is always feels a bit like a sort of politician's answer to the question. I think there are a number of options. I think with a long-standing spinal cord injury, all your urology care doesn't need to be provided through the Spinal Injuries Centre. And it may be that this is something that your local urologist can deal with. And I often say this to my patients who have driven hundreds of miles to come and see me, when their problem may be recurrent urine infections in a very long-standing spinal cord injury, and they can have an ultrasound in their local centre, and their local urologist will be very competent at dealing with recurrent infections. And so I think that would be my first suggestion to explore, and seeing their GP and asking for a referral to their local urologist. I think anybody with a neuropathic bladder who's having lots of urine infections should see a urologist, because there may be something that can be treated. In terms of surveillance, again, I think this is really tricky. And in our spinal unit, we do have a system whereby patients are seen for some kind of imaging of their kidneys on some kind of regular basis. But I do not think that that's necessarily every year or every 2 years, simply because of the large volume of patients. I think if you are plugged into the spinal unit, then to speak to your spinal injuries physician, or one of the specialist nurses in the unit, and potentially even the urologist within the unit, and explore the options as to, do I need some surveillance? Should I be having an ultrasound at this point? So I think those are your 3 ports of call: your GP, your local urologist, and then if you are involved at your spinal unit, you have got a clinician connection there, then getting in touch and saying, I feel worried about this. I think those would be my top pieces of advice.
Perfect. Thank you so much. I mean, we could carry the Q&A on for much longer than we've got. I'm very conscious of the time. And sadly, we're going to have to bring things to a close. I'm hoping that you found this evening's session to be informative and practically useful, and to support you to better understand your bladder and ways to manage it. We would love to hear feedback on how you found tonight's session. You can complete a very short survey by scanning the QR code or by following the link that we're going to send tomorrow. The feedback will support us, of course, to understand what we can do better, what topics we can bring up in future spotlight events, and, ultimately, if there's things that didn't quite work for you, how we could look to improve and make changes for next time. I'm delighted to announce that our next event is taking part on the 12th of March. And it will be shining a light on the topic of travel, which some people have been talking about in some of their questions this afternoon or this evening. So we will be joined by our panel of therapists and various guest speakers for that, and it's already lining up to be a fantastic event. I would love to take the opportunity to once again thank all of our guest speakers, Sheila, Katie, Ian, Miłosz, Mel, Carol, and of course, Ian, our trustee, as without their expertise and time, tonight's event would not have been possible. I'd also like to say a huge thank you to Karen and Ella, who have been working tirelessly behind the scenes to ensure the event runs smoothly. And lastly, I'd like to thank all of you. We've made history this evening with not only how many people joined us, but how many people signed up to join the event in the first place. And long may it continue to grow in the numbers sent. I hope you enjoy the rest of your evening and you've taken things away that you'll be able to pause for thought and think about. Thank you, and a very good night to you all.